Dr. Mark Sarkel. I'm the Chief Medical Officer at Meritage Medical Network and a practicing geriatrician and internist in Novato in Marin County, and welcoming you to this hopefully 20 to 25-minute presentation about risk adjustment and our risk plans that we now have throughout our Meritage network. So let me just jump right in since I know you're busy. Go to the next slide. So I think, and many of us think in the insurance industry, that the name of the game in the future is assuming risk, particularly for Medicare patients. These are the ones, especially in Marin County and the northern counties, that are a growing part of the population. They consume a lot of resources, need surgical procedures, specialty consultations, as well as primary care. So there are three flavors of insurance companies I'll be talking about. The most important is Medicare Advantage. Medicare Advantage is a Medicare plan whereby Medicare or CMS has contracted with a payer to provide healthcare services for its Medicare patients. The payer, let's say United, for example, then contracts with the medical group to provide those services. Thus, we are capitated at per member per month, and depending upon the amount of money we spend caring for these patients, we either get a leftover in the end of the year or we have some risk at the end of the year. The advantage for these Medicare Advantage plans are that they're much less expensive for our patients. The maximum out of pocket is limited, I think, to 5,000 or 6,000 as opposed to 8,000. There are more services available to the patients, including case management and behavioral health services. And the average monthly premium is anywhere from $0 to about $75, much better than if you get a commercial secondary. For us, the advantage is we are using our doctors, our institutions, our hospitals, and we are keeping our patients in our network and able to case manage them and care manage them better. CMS over the past 15 years has pretty much enjoyed a 1% to 2% decrease in Medicare expenses by moving patients to Medicare Advantage, and now about 1/3 of Medicare patients are in these Advantage plans. So how do we do well? First and foremost, we continue our excellent and high value care. Every metric that we've looked at that is relevant, such as admissions per thousand, readmissions, ER admissions, looks very favorable. I think we're all doing a very good job. But that's only part of it. The other part of what determines how much money we get from the plans and CMS is how we capture high value codes in our documentation. If we don't code properly, Medicare will think we have a healthier population and we won't get as much money for the care we give. The third thing, which I haven't talked about in these sessions before, is there is a movement towards making the capitated payments from the health plans dependent upon whether or not we satisfy certain quality metrics. And I'll get into those in a few slides later. So that's Medicare Advantage. Next slide. Traditional Medicare fee-for-service that we all grew up with covers Part A, and I was very pleased to get my Part A card a couple of years ago, but that's only the hospital, and Part B, which is outpatient. Patients with this have a copay of 20%. So almost everybody, if they don't have Medi-Cal, gets a secondary insurance. These plans are not connected to any IPA or to Meritage. The advantage to patients is they can go anywhere. They can go to UCSF, any place that takes Medicare, they can go to. They don't have to ask their primary. They can just show up. For us, it is much more difficult to coordinate care, control costs, control the network. Medicare also has fewer available services such as mental health. And for us as an IPA looking out for our docs, there's a lot of leakage to other organizations, particularly in our network to UCSF, where care is much more expensive and then our specialists lose the business. For CMS, the costs are modestly higher and the benefits, as I said before, are not as good. So how do we succeed in fee-for-service Medicare? Proper coding is still important, although the HCC codes that I'll talk about are not as relevant. We want to improve scores on the ACO quality metrics. There are about 90 of these. Maybe I misquoted that, but a lot of them. But many of you in your own private practices are capturing them. And finally, we encourage patients to migrate to an MA plan because they stay with us, our docs, our hospital, and we can manage them better. And in fact, if you take the time to transfer a patient from fee-for-service to Medicare Advantage, we'll give you $100. We can figure out that you did it. And that $100 is not a bribe. It's basically to pay you for the extra time it takes to care for an HMO patient compared to a fee-for-service patient. So that's Medicare fee-for-service, a shrinking part of our business. By the way, I will say that all the big organizations, Sutter, Kaiser, UCSF, are looking at Medicare Advantage because they know that's where the money is. That's where the gold is. Okay, so back to the third plan group, and these are commercial plans. Medicare, Meritage in general holds HMO contracts. We have some PPOs, but by and large, we hold the HMO contracts. And for us, that is mostly Western Health Advantage. That's half of our commercial patients. And all the doctors I care for who are in private practice have WHA because it's the least expensive plan. The premiums are cheaper than Kaiser. You can get them through the exchange. Often they're high deductibles. So some patients want to see me and they want me to do everything during my physical, from diabetes management, hypertension, depression, and bill it all as a physical, not really doable. For us, though, we have the same, for us as Meritage Physician Group, we have the same up and down side for high value care. And this is obviously not relevant to CMS. So how we succeed in commercial risk, which is WHA HMO for your purposes, is basically the same thing. Instead of RAF, they call their high value codes PLRS that are fairly similar. Asthma is a PLRS code that is not a RAF code for some reason. Don't ask me why. We want to do well on our Hedis quality metrics, which is a much bigger universe of metrics. And we want to continue our excellence in high value care, which we seem to be doing. One further thing there is we really want to get patients with complex conditions. We want them to see the doctors at least once a year so we know what's going on with them and can capture their codes. Next slide, please. So I'm going to talk a minute about quality, and here's a three-ring circus of quality. There's a certain quality that you and I think reflect that guy's a good doctor, that gal's a good doctor. And it's based upon their skill, their knowledge, their behavior, maybe their empathy, their ability to communicate. And that's the most important part of quality. Then there's quality reporting. And those are the metrics that I mentioned, such as 5-star or Hedis, which could be up to 90 categories that we kind of do our best to check off the boxes. They're almost always process metrics. They don't really reflect outcome, although for sure, I think I'm doing my patients good if I'm doing colonoscopies and mammograms as indicated. Now, a subset of those quality reporting metrics are discoverable based upon, do we get the information from claims? Are in their right spot of the EMR? Can I find something in, or my team find something in a pile of faxes? So the intersection of all those things is what quality is. And it's a very small part of quality, as you can see. And I think this is useful because when I talk further about quality metrics, I'm not pointing the finger. It's just that some things are arbitrary from quality metrics and some things are discoverable and they overlap only with some of it is what it is about being a doctor. Okay, next slide. So these are the key quality metrics that are used by healthcare organizations. 5-star, which is a manageable number of metrics, has to do with the MA plans. This is most important because patients can see on the website if we're 3, 4, or 5 stars. Kaiser is almost always 5 stars because of their support system for everything. We in the IPA have been 3 and hopefully 4 stars this year. Key metrics are things you all believe in: cancer screening, diabetes care, medication adherence, and so forth. Then there's the Hedis metrics, which are about 90 or so, I guess I remembered that are reported to the NCQA. Almost all the 5-star metrics are in Hedis, and they include things for immunizations, chlamydia screening, fall management, asthma, medication using controller inhalers, and so forth. And then there's the Mips metrics. I think many of you are familiar with those in your practices. And these are selected quality metrics reported to CMS to see if a group is eligible for shared savings. And we are focusing on some of them as well. And we are trying to get a subset of things that we all kind of believe in. Okay, next slide, please. Next slide, please. Okay, great. These are the 5-star quality metrics, and they all look completely reasonable. And I'm just going to look at a few of these with you. Breast cancer screening. This is for Marin. We're taking global risks, so this is a little bit more important. You can see now that we're at a current rate of 67%. We need one more patient to hit a 5-star rating. Colorectal cancer screening, we have a lot more eligible members. Our current rate is only 42%. It's probably not 42%. It's probably 60%, but we can't find all the colonoscopy reports. And we need a whole bunch more colonoscopies to hit 5-star. And we go down the list. For the you ophthalmologists here, we need a lot more eye exams. We do pretty well on kidney disease monitoring, which is basically getting a UA for microproteinuria. We have a lot of poorly controlled diabetics, but that's because they haven't gotten their A1C, or we don't know what their A1C is, and we haven't hit 5 stars for that. The worst is controlling blood pressure, and that's about 1/2 to 2/3 not finding the data, or the data is the wrong spot in the EMR, and I'll be talking to primary care about this. Or sometimes there's a certain clinical inertia about following up on blood pressure. The metric is less than 140/90. Many of us who are older think it's perfectly fine to have someone 148/70, and we might not do anything like see the patient back. So these are the things. If there's a rheumatologist in the group here, using DMARDs is important. Looks like we've hit 5 stars already. Statins in patients with cardiovascular disease, you would think everybody who sees a cardiologist is on a statin, but apparently there's 3 more that have to be found. And then we have adherence measures, which are very important, that actually our team calls patients and said, did you pick up your drugs? Did you pick up your drugs? There's one thing I also want to mention for the orthopedists in the group. If you admit an older person with a hip fracture, please put in your discharge summary, get a DEXA scan upon discharge, or order it yourself. CMS has determined that, and this is true actually, I can tell you from my nursing home practice, patients will come with spine fractures or fragility fractures and not be placed on osteoporosis medicines within that year. And they're usually, have osteoporosis. Okay, so our average rating right now is 3. We think we might hit 4 this year. And obviously, we want to be at 5. And the higher the star rating, the less money we'll lose on our capitation from the health plans. Next slide, please. Okay, I'm going back to things that you might have heard from me before. This is going to capturing high value codes. The basic definitions are the RAF, risk adjustment factor. And those are a set of conditions that CMS has determined by an enormous database are associated with more expensive intervention tests and follow-up. And the risk adjustment factor consists of a demographic factor, age, gender, and also the capture of hierarchical condition categories. And those are point values ascribed to properly billed diagnoses. We all can help with this. Most of it falls to primary care, endocrinology, cardiology, oncology, but everybody has a little bit of a role with this. It's important that for all of us that you document properly, and I'll go over that because it's true for anything that you do. And I'll tell you that as an IPA representing your interests and to some extent the amount of money you make, the better we do, the more we'll all be able to share. Okay, next slide, please. Okay, so RAF is important not only to make money for the IPA, but it levels the playing field. If our RAF in Marin is 0.9, and that's a true RAF, our patients are a little bit healthier than, let's say, Sonoma, where it's probably 1.1. And that tells you that we expect your patients to be more complicated, to use more resources than we do in Marin. Patients with high RAF scores will benefit from case management, and we reach out to those patients. Maybe they need help getting their medicines or not going to the ER necessarily. There's some very bad data that shows that capturing HCCs improves quality. And since I put that slide together, I can't find that article anymore. So don't ask me for it. And finally, I do want to point out that risk adjustment is a way of essentially underwriting. Underwriting, the insurance company goes to a group, looks at its demographics, its history of smoking, its history, and says, okay, you'll cost, $300 a month. What risk adjustment does is they look at what physicians document, and a year and a half later, they'll give us or take away money based upon how sick or unsick our patients were. It's more accurate, but it's certainly not a good business model for us physicians. Okay, next slide, please. So here's an example of, is this Esther? Yeah, this is Esther. Esther is 92. She likes hip hop. And she has these medical conditions: systolic heart failure, rheumatoid arthritis, functional quadriplegia. Functional quadriplegia means she needs extensive assistance getting out of a wheelchair, and that's very much underdiagnosed. So even, you orthopedists who have someone who has end stage, rheumatoid arthritis or spinal stenosis, you can code this once, because I might miss this as a primary care physician. Note, for example, that the RAF for functional quadriplegia is almost 4 times what it is for systolic heart failure, telling us that people with functional quadriplegia who are wheelchair dependent cost more than people with systolic heart failure. So if we add all this up and we do a risk factor normalization, we find out that Esther's RAF is 2.3, and do we have 2.3, which is very, very high. And it is high because Esther this year or next will cost us a lot of money. She'll go into the hospital. She'll be on 8 or more medications. She'll have a GI bleed from them. She might have a bowel obstruction and so forth. Okay, next slide, please. So how do the economics work? Again, this is a little bit repetitive, but I do want to make the point that we capture all the HCC codes in RAF in year 2020, and they all go back to 0 the next year. So for example, if someone's had an amputation, once a year we need to document amputation of the toe, status post amputation of the toe. That's a RAF of about 1.5. If we don't do that, Medicare believes the toe has grown back and doesn't give us credit for it. So basically the severity of the disease is based on the diagnosis codes that are properly captured, which leads to a RAF, which leads to monies generally going back to the IPA. When we started this 6 years ago, we lost about, $1 million. And then 3 years ago, I think we broke even. And now last year was a bad year, but in general, we make a little money doing this. Okay, next slide, please. All right, changing gears a little bit, I do want to point out for all of us, because this is the standard for all insurance companies and all auditors, what they want to see in our documentation is diagnosis, logic or status, and the plan. And what that means is that we code the ICD-10 code, which we all do. We then note how we came to the diagnosis, like pneumonia based on chest x-ray, based on auscultation, or stable if it's an old problem. And then we say what we're going to do. And that can be as simple as continue current management or no change. Next slide. So this doesn't really have to take a lot of time. For new diagnoses that might be RAF, Meritage coders will help the doctors, or at least the primaries, identify these codes. And for new diagnosis, you'll say how you figured it out. So a HCC code, abdominal aortic atherosclerosis, is something I never learned about in medical school, but I code every single year on about 25% of my patients, and I write incidental finding on ultrasound that I may have gotten to screen for an aneurysm, aspirin recommended, or secondary prevention, or monitor. Existing diagnosis, wherever possible, we try to code with greater specificity. We see a lot of people coded as type 2 diabetics. There is no type 2 diabetic. Every single diabetic has type 2 diabetes with complications. Try to refine the code to that. And you make an evaluative statement. A1C 7.2%, LDL is a little high for diabetes. Our plan, continue metformin, increase Lipitor. Major depression is an example. Probably most of you aren't coding this, but we would say, you know, PQH9 is a screen, S in remission, continue Zoloft. Okay, next slide. Here are some of the codes that are missed. Diabetes with complications I mentioned. Major depression, many patients are on Zoloft or related drugs. If you are on a medication for depression, you have major depression. It may be major minor depression, but the word major has to be in there specifically. Otherwise, it doesn't risk adjust. And my patients say, hey, I don't have major depression. I say, well, you want me to stop the Zoloft? They say, no, don't stop it. They have major depression. Same thing with opioid dependence. Everybody here, not everybody here, but probably half of you in specialty services will use opioids. If you have someone with chronic back pain that you're prescribing opioids on a regular basis, they have opioid dependence. They might not like hearing that, but that will help you taper them. So I use that for all my chronic pain patients. And the same thing for even my sophisticated patients who can't live without their Ambien prescriptions, and those are things that risk adjust. Asthma, I mentioned, this would not happen for a pulmonologist, but sometimes in primary care, we'll give an inhaler and we won't diagnose asthma. Okay, next slide. For interest, these are other HCC codes that you might not think are that important, going to medical school, residency, and fellowship. And CKD, GFR 59 is CKD stage 3. It counts, which is, I guess, appropriate. Secondary hypercoagulable state, if you have persistent, not paroxysmal atrial fibrillation, that is worth coding. CNL purpura for the dermatologist, please find it in every one of your patients over 65 and document it. Emphysema, even if your patient is asymptomatic and it's seen a patch on CT scan, we'd like you to put it in. We talked about functional quadriplegia. For the neurologist and physiotherapists here, late effective stroke. Stroke is not an outpatient diagnosis, but you'll have a lot of people with hemiparesis. Please code late effective stroke hemiparesis. That's the only one that RAF adjusts. Sick sinus syndrome cardiology, if you still have someone on a beta blocker, even though you've put a pacemaker in, they still have sick sinus syndrome because you're treating the tachycardia still. If you don't, then you don't. And finally, my personal favorite is alcohol dependence in remission. I love alcoholics in remission. They're very interesting people and they're not drinking. I still code that, and any serious alcoholic in remission knows that he's an alcoholic in remission and won't mind seeing the code. Finally, for everybody, if you have someone with cancer, please code the metastatic site of the cancer. So breast cancer might be a RAF of, I don't know, 1.2, but breast cancer metastatic to bone has a RAF of 2.4, much more important because it engenders more services. All right, almost wrapping up here. Next one. Here's some other updates. Pressure ulcer, I think you'll be doing this automatically. Dementia was not an HCC code 2 years ago, but now it is. So that makes more sense to me as a geriatrician. Next one. Okay, so here's a quick case study. This lady is 82, severe RA, though it doesn't look it from here. Needs complete assistance with transfers, atrial fib, pacemaker, and she's on metoprolol, Xarelto, sertraline, and methotrexate. What are the high value codes that are likely? And she's got fibrillation. She's got a secondary hypercoagulable state. She's got major depression because she's on Zoloft. She has functional quadriplegia because she needs a lot of help out of the wheelchair. I'm assuming she has senile purpura since she's old and on Xarelto. She has RA. She has sick sinus syndrome. Even though she's had a pacemaker, she's still on a beta blocker. And we add these all up. Her normalized RAF is about 2.9, which means that our medical group every year will get about $10,000 for our risk program. It will be twice that if it's global risk, as we have in Marin. So it's important to capture these codes. Next slide, please. Or is that it? Oh, okay. So how are we helping? I do want to again point out that Meritage is not an insurance company. 85% of our profits goes back to you guys in forms of incentives or practice support. We think that risk plans are our future, and risk plans will have something similar to RAF, some kind of barometer of how risky a population is, how much they should cost. So it's important that we capture those codes and capture the quality metrics. For primary care doctors, I have one-on-one face-to-face training. We help them identify codes. For you guys as specialists, this is your education for the next year or two. And I'm happy to meet with any of you privately if you like, especially with your group. And if you want coding guides, usually these are embedded into the EMR, but if you want your own personal coding guide, we've made them for almost all specialties. And we will do some chart chasing at Meritage and audits to see if we can find codes that are missing. Okay, anything else? And this is a real pain. I mean, everything in medicine is a pain. 2/3 of my life is data entry. I hope it's better for you guys as specialists. I assume it is, but it may not be. But we're providing the care. We need to be recognized so we can compete with the big boys who have better contracts, who have integrated models. And we are taking facility risk, and that will extend, we hope, to the entire network. And that will increase our risk, but also our benefit if we manage our patients well. RAF will help us choose out the patients who need special attention. And sometimes we'll find conditions that were previously unrecognized. I look at a lot of notes, and complete physicals will miss that somebody is missing a toe or has a colostomy. Those are things that once a year really should be coded. And it's a good opportunity to remove codes that shouldn't be on our problem list, like sepsis, small